IO is easy, and to sign up is just as easy. Meet Abel Mutula from the barbershop in Kalingalinga. Abel Mutula is also an IO customer.
My name is Abel Mutula. Signing up with IO was easy. This is how I signed up. Step 1, dial *296#. Step 2, select one, sign up. Step 3, select either one for my hospital or 2 for my life. Step 4, fill in your age and confirm. Step 5, select 1 to accept the IO terms and conditions. Well done, you signed up. Now let's add my loved one.
IO together with MTN. IO, because you care.
Hello, good evening, and welcome to today's conversation. As usual, do tell us where you're watching us from. So, like we promised, today we are discussing the issue of breast cancer. So, I hope you've tagged somebody, you've invited someone. So, and also, please do tell us if our sound is good. We had issues with our sound previously, so I'd be happy to hear from you if the sound is excellent. Now, this is a topic that you don't want to miss, and this is a topic that you want to make sure that people that you care about are here and they're able to hear for themselves. Because today, we are an international expert on the subject of cancer in general, except that today him and I will focus on breast cancer. In future, we may discuss other cancers. Now, this month is Breast Cancer Awareness Month. And so to commemorate this particular important period, as a page, we felt that we bring you an authentic expert to tell us about breast cancer. And that's what we're going to do today. We'll discuss issues to do with breast cancer. So without much ado, let me introduce you to my guest for today. I am joined by Dr. Paul Chilwesa. Now, Doc, welcome.
Thank you very much, Dr. Mjajati. Really appreciate your invitation. It's an honor.
Right. So, Doctor, very quickly, tell us about yourself. Quickly introduce yourself, who you are, and yeah.
Thank you. Simply, my name is Paul Mambo Chilwesa. I'm a clinical oncologist by profession and training, currently heading Roche Policy and Partnership for Southern Africa. I'm trained in Zambia at the University of Zambia for my graduate in medicine at the Ridgeway campus, specialized at the University of Cape Town in clinical oncology, and did a few of my fellowships abroad. I think that's okay. In summary.
Now, tell us a bit about Roche, Doctor. Who is Roche? What is Roche? And yeah, why are they important in the space of cancer?
So Roche is a Swiss biotechnology company that spans expertise in diagnostics, meaning how we make a diagnosis for a lot of disease processes, therapeutics, basically treatment, and we also have an arm for diabetes. But our main strength and majority of what we do, 60 to 70% of our portfolio is dependent on cancer. We do have a lot more other health-related programs that we do and diseases that we cater for. As we are aware right now in the COVID era, we're also the providers of some of the kits that are being used in testing. We are also the major players when it comes to HIV diagnosis. But when it comes to cancer, Roche strength and majority of what we do, as I said, about 60% of our diagnosis and treatment is cancer related.
Excellent. Now, let's talk about this issue of breast cancer. We are in the Breast Cancer Awareness Month, the month of October. Tell us a bit about that and the theme and how Roche is involved in this particular period.
Thank you very much. I think globally, the Cancer Awareness Month is talking about people rising to the occasion in terms of what we can do for affected and prevention of breast cancer. But in terms of what we are doing as Roche in Africa, we're talking about time to check your breast every 30 days. And those are the campaigns we are running on the social media platforms, on our social media platforms, which is Facebook and other social media platforms. When it comes to tapping into what the world is looking at in terms of breast cancer, and we are going along with the authorities when it comes to who decides some of these things, with WHO and other important organizations. We are talking about how can we rise to the occasion of creating awareness in breast cancer, where breast cancer affects both men and women, but of course disproportionately more women.
Okay. So, Doc, as I'm sure I mentioned to you that at some point we are going to take questions
Absolutely.
from make sure that this issue of breast cancer is discussed fully. Now, just to set the ball rolling, what is breast cancer?
Sure. So, and I think some of these terminologies are along the way to help us make sure that people understand it better might have to be changed, but we'll still have to call it breast cancer. So a cancer, first of all, I need to define a little bit about what a cancer is. It's basically a cell in an individual inside someone that has decided not to follow certain instructions that the human body follows through. A cell at some point ages and then it dies off, especially the cells that replicate. But for a cancer cell, it stops to respond to stimuli, which tells us to age and to age. So this cell just continues to multiply and multiply and multiply, and eventually forms a big mass, and that mass then, when we see it, we call it cancer. And there's sort of what we conventionally call cancer is the one that has sort of spread outside where the original cell was. So meaning a cell that has invaded what protects it, called the basement membrane, is what we most of the time we call cancer, but that's called invasive cancer. But the one that has not passed through is the pre-cancer, before it becomes cancer. But both of those are actually cancer. So there's a benign component of cancer, meaning it has not gone through the protection layer called the basement membrane, and there's a more dangerous one, the invasive cancer, which has gone through that protective layer called the basement membrane. So breast cancer is basically that cell that has gone through those changes, which occurs in the breast. And as you are aware, men and women equally have breasts, and because of the disproportionate sizes, women are more affected with breast cancer than men.
Right. Now, tell us a bit about, in terms of spread, how common is breast cancer and who is mostly affected?
So I think, as I had mentioned earlier, breast cancer disproportionately affects women because of the difference in the volume of the breast compared to a man. So women are more disproportionately affected when it comes to the sex disparities. When it comes to race, we do understand that the white race is more affected. It's more common amongst the whites. But the unfortunate aspect about that is that the other races, the blacks and other races, are more disproportionately affected in terms of death from breast cancer, meaning we get a lot more dangerous breast kind of cancer. As of 2020, previously, prior to 2020, the most common cancer globally was lung cancer. And that has been surpassed right now by breast cancer. So the most common cancer globally is breast cancer. So it's quite a big issue, and it's quite something that has to be sort of tackled. And I think we saw that the WHO in March, on International Women's Day, announced some of the mechanisms that they were going to take to reduce sort of the impact of this disease. Why initially I opened by saying we might need to change some of these terminologies is that breast cancer is not one disease. And I'll explain a little bit on that if you give me a few minutes or a little bit of time.
No, go ahead. Go ahead.
Yeah,
Go ahead.
is that it's called breast cancer because it starts in the breast, but the actual disease process is not the same. And I try to tell this to people to understand that the experience of one who has breast cancer is not going to be the same if you get breast cancer, because there are so many different types of breast cancer. And the four main ones that we talk about in science, in medicine, and the ones that we target with our treatments is there's what we call hormonal type, which is the one that is estrogen driven. And there's one that we call HER2 type, meaning there's a particular receptor that we've picked up on the surface of the cell. And there's one where we have not picked up any receptor, and we call it triple negative. So eventually we need to move to a stage where people understand that breast cancer is called breast cancer because of the organ where it starts. But the science is very different, and one breast cancer is not the same cancer that you see. And the way I narrate this to people to make it easier to understand, I think most of us come from big families. We have siblings of a particular number, right? You might have 5 siblings. There's no way you can go into the Mjajati home, and because you've met the parents of the Mjajatis, you say you understand every Mjajati's child. It's the same thing with breast cancer, because every child will have their own character, okay, in as much as they all come from the Mjajatis. So it's the same thing with breast cancer. They might all be coming from this same tissue, but because they all have differences in the way the genetic makeup is made in every person, the differences are very obvious. And we're now going into the phase what we call in personalized healthcare. And hopefully at some point, hopefully in our lifetime, the way we name cancer might be different.
Right. Now, I'm sure the people who are watching us want to know, what are this cancer? Like, how can a woman know that I now have breast cancer? What are the signs and symptoms?
So one of the things that I encourage people, I think, especially that we're talking about awareness, and we're taking our hats off to women who survive breast cancer and those who are helping the breast cancer. And I think I would like to sort of give a big shout out to the Two Sisters Foundation. They're doing a great work in Zambia, and the Zambia Cancer Society. They're doing a great awareness. And I think when we talk about awareness, we're sort of saying from our professional side, can we sort of have a co-shared responsibility with the disease, with the community and the patients? So when we talk about how do people know they have breast cancer, I always say the best way is to be checked before you know, because by the time you find or you feel something, most of the time it's a little bit more advanced. I'll go into the symptoms, but what I think has to be loud and clear to everybody, especially women, because for men it's a little bit more difficult and complex in screening. For women, you need to go for screening before you feel something, because by the time you feel something, it might actually be a little bit late. So what is breast cancer? As I said, it grows in the breast. It's a cell that has decided it's not going to listen to the signals that the body sends for it to behave. So it's just gone haywire, and it's growing and growing and growing and becomes big. So one of the symptoms that we know is a lump. Okay, the common thing that we feel and see with patients is a lump. Because the breast grows in either where the milk is produced, in the lobules, or where the milk passes to come out from the breast in the ducts. Those are the common areas, and that's the commonest kind of breast cancer that we know. So because of that anatomy, you might see some discharge from the nipple, usually bloody discharge, not really milk, coming from a woman, and that can also be a sign of breast cancer. And because these tissues are sort of created to make into an organ, they can, if one tissue is affected, the other organ can also show that something is wrong. So you might see a bit of change on the skin. You might see the nipple changing the position. You might see the nipple turning inside, because we create an invasion of the nipple. And you might actually see an obvious ulcer. The skin might open. So that's what we see on the breast itself because of the presence of the lump. And there's also certain subtype called inflammatory breast, where you might not even feel the lump. You just see a very red, painful breast. That can also be a breast cancer. And because breast cancer, I should state that even early disease, 50% of patients who are presenting with early disease, they have what we call circulating tumor cells, meaning the cells have broken off from the cancer and is going into the system. So because it goes quickly into the system, you might feel a bit of lumps under your arm, a little bit more bigger and less painful than when someone has had an injury because of shaving under the armpit. And those are some of the signs and symptoms that we see in breast cancer. But again, as I said, I need to say, please don't wait for those signs. The best time to catch breast cancer is before you can feel it.
So what you're basically saying is that in as much as you have all these signs, by the time you are feeling a lump in your breast as a woman, it's a bit too late. That's what you're saying.
It's not always too late, but commonly it is too late. So our staging mechanism, and which is also going to change along the way, is so much dependent on the size and presence of lymph nodes. How big is something in the breast itself, and is there lymph nodes under the arm? So most of the time when you feel that, it's already gone into past stage 2B, and once you cross stage 2A, you're already being considered advanced. And the cure is there, it's possible, but a little bit more complex than if caught early.
Right. So now, if a lump, if by the time a woman finds a lump in the breast, it's too late, what then should they be doing?
So first of all, as I said, this is Breast Cancer Awareness Month, right? So what we are saying in the medical community and globally from other authorities is that we want to sort of co-share the responsibility of this disease. Okay, and as you are aware, there's multiple cancers that exist out there. So we want to raise awareness on cancers that we can either prevent, like cervical cancer, or the ones that we can treat early enough and save a life, like breast cancer. So awareness part is that someone has to be aware of what their breasts are like. Okay, so that if there's any change or any remote change that they feel or see, then they need to seek medical care. Okay, unfortunately, that's not a recommended screening method. It's something that is important for you to be aware of your own breasts. What is important is that you get your breasts checked by a medical profession in two ways. One of the ways is called clinical breast examination, meaning an expert, okay, like a Dr. Mjajati or another surgeon or some other expert, a doctor, a nurse, trained, given the skill to be able to examine, can feel correctly what is in the breast if there's a lump, and under the arm if there are any lymph nodes. That is called clinical breast examination. The second way is that if they feel there's something that they might need to check or you're at risk, then the medical profession will give you the next stage of how to screen, which is radiological. So you can have so many modalities that exist. I know the commonest one is mammogram, but this is risk dependent and age dependent. I'm not going to go into a little bit detail there, but I'll leave it to the medical profession. When you need to go, then they give the right modality.
Excellent. Now, the thing I want to hear with regards to screening for breast cancer, one of the questions that women keep asking me a lot is how often? And in some screening is not free, you see? So how often should they be going for screening?
Okay. So screening, by definition, is when there's no disease. Okay, you're feeling well, you're a well person, that is screening, because you want to check for disease if it's there. Once you feel something is no longer screening, it's a diagnostic checkup. So screening for breast cancer is dependent on three things. Maybe I would sort of break it down to three things in terms of awareness, but there's a lot more that we need to sort of look at before we recommend a screening. One is, what age is the patient? Okay, if you're younger than 35 and there's no other risk associated, meaning there's no one else in the family, there's no risk of breast cancer in your family, we do not recommend for someone to start a screening yet. Okay. If there's a lump, which is common, fibroadenomas in the younger patients, then you need to go and get it checked. But in terms of routine screening before the age of 35, there's no actual recommendation around that. Okay, that's one group. The other group of people that have very high risk of breast cancer, in where first degree relatives have had breast cancer under the age of 50. You've had a young person in the family who's had prostate cancer, so very linked to what we call BRCA mutation in the scientific term. Then those should be screened at least 8 to 10 years prior to the diagnosis of this younger person, first degree relative. But it's a bit more complex. But the point is, if you're someone that feels there's a lot of breast cancer in your family, you need to go early, and the doctors will sort of recommend at what age you should be screened. Then if you're above 35, okay, then we now have what we call stratification. So we can say if you stratification, you can say if you're 35 and you get a screen, we'll give you an appointment in the next 3 years. But you're much older and the risk is much more, because the older you grow again, the higher your risk of breast cancer. And other risk factors that might have been associated with you, we might give you a much shorter interval. So we do not have one line that says every year, every second year, every third year. It's very dependent on an individual, and this is also the beginning of personalized healthcare. So my advice to people is, before you feel anything, before you feel any symptoms, go for screening, and your healthcare workers will be able to advise you when your next screening should be, because it's not a general rule for everybody.
Now, tell us, what are the risks of breast cancer? So, who is at risk of developing breast cancer?
Thank you for that. So the number one risk, I think, for almost every cancer is age. Okay, as every one of us ages, we are all at risk of some cancer. Okay, so as the body ages, the body gets less efficient. So there's a way that some of these control mechanisms that exist in the system, in the body, are no longer as effective. So everybody sort of gets at risk. So the most common age group actually for breast cancers in the West is people in their fifth and sixth decade, meaning 50s and 60s. That's the first one. The second one is people who've had what we call long exposure to estrogen. Okay, unopposed estrogens, meaning people who've been on a long contraception where it was involving estrogen. So if you look at this condition,
you have to explain that properly.
So birth control, I think that's contraception.
So which type?
So we're looking at unopposed, the ones that are only have estrogens in them. Okay, the unopposed one. I think I'm sure your gynae should be able to to be better at this in terms of explaining that. But the important aspect is that every condition that exposes a woman to increased estrogen, okay, creates a problem. So then if you look at conditions that we're talking about, obesity, okay,
yes,
the fat cells have a way of producing estrogen, so you're now getting a longer exposure. So those things give you a risk of breast cancer. Alcohol have a way of affecting metabolism, which I know Dr. Mjajati will be better at explaining the metabolisms through the liver. So you get more exposure to estrogens. Okay. Women that have a first child later in life. Okay. So they have had a longer exposure to unopposed estrogens because they've never been pregnant. So that didn't stop that cycle. Because every time the breast gets exposed to estrogen, some of the cells in the breast go through a cycle, and because of that continuous change, you are at risk of breast cancer. So we dwell more on conditions that we think have increased exposure to unopposed estrogens create a risk of breast cancer. Alcohol intake, obesity. This is why people are talking about exercise as one of the risk aversion mechanisms. A good diet, vitamin D, and all these other good things that I've seen people talking about in terms of lifestyle. So those are the things that are reducing your risk. But then there's a very important aspect, I think, which I should have mentioned, but I'm trying to be as less scientific as possible. We know that there are certain inherent risks that we carry over from generation to generation, and those are sort of 15 to 20% of breast cancer is genetic. So if you are coming from a family that has had breast cancer or other cancers that are related to certain genetic mutations that a healthcare worker can pick up, you have a very much high risk of breast cancer. Secondly, if you have had breast cancer yourself, or you've had ovarian cancer yourself, there's also another risk associated with you getting a breast cancer. So being a breast cancer survivor does not mean you cannot have another breast cancer. So you need to continue checking for breast cancer. So those, I think, are the main risks, and we do try and say which ones are modifiable and which ones are not modifiable. The non-modifiable ones is you can't change your sex. So being a woman is a high risk. Being born in a particular family is a particular risk. But one thing you can modify is you can modify obesity, you can modify your alcohol intake, you can modify your hormone replacement therapy, and you can have these discussions with your physician when you are being put on some of these medications.
Now, Dr. Chidwesa, alcohol consumption and alcohol abuse in our country is very high. Okay? Are you therefore saying that our consumption of alcohol is bordering on exposing to breast cancer?
Absolutely. So I think there's a very clear definition of which one, what we actually call abuse. Okay, how many units in a week, and dependent on sex, someone is at risk.
I need you to repeat that a bit, doctor. There was a glitch in our network. I sort of missed what you said. Just repeat what you said.
So I don't know if you can hear me.
Breast cancer. I can hear you clearly now. Alcohol and breast cancer. Could you repeat that?
Yes. So alcohol is a high risk for a lot of cancers, actually, but for breast cancer, I think it's more to do with the estrogens that the estrogen production that it affects, right? And metabolism of estrogen. But then alcohol has been put into a very clear, in a scientific way, how much is good, how much is allowed in a week, dependent on your age, your weight, and your sex. How many units you are, someone is allowed to take. Once you cross that path, then we are talking about alcohol abuse, right? You're talking about risk. Those are things now that we're now moving into a risk group. So once you go beyond those accepted limits per week, per day, for your age and your sex and your weight, then those are now increasing your risks. So when we talk about risk, and this is the thing that I think has to be made clear, you stopping alcohol does not reduce your risk to zero, because there are so many other risks, but you are reducing your risks. If you are at risk for let's say 2.5% higher than the general population, you might just come down to the general population. So when we calculate risks for cancers, what we are saying is, if all these modifiable factors were removed, this is what the general population is at risk for breast cancer. It's not zero, but we want you to reduce your risks so that there's the chance of you getting breast cancer is lower. Remember, I said 15-20% of patients genetic, 80% common is just, I don't want to call bad luck, but it's just not, you cannot predict exactly the 80% who will get breast cancer. But because we know some of these risk factors, some of them go above the normal general population risk. And I think I should state that, I think because of this show as well, breast cancer will never come from outside. It will never be because someone put a spell on you, or someone injected it in you. It's something that happens because a particular cell in you. So it's the you that has changed because of a few things that has happened in the body.
So, very, very short. And then when we come back, we're going to take questions from the people who are following us. I've seen a lot of questions in the comment section. And also, you and me are going to discuss issues to do with treatment. And we're going to also dwell a lot more on what should a woman do now to prevent breast cancer. Those are the areas I want you to come and also take all the questions that are in the comment and then from our sponsors.
What can you do with 5 kwacha? Not a lot. A 5 kwacha Auto Boost can get you 1,900 kwacha extra IO cover. Bernard Mulindu auto boosted, and Bernard received a total payout of 2,070 kwacha when he needed it most. Here is Bernard's story.
My name is Bernard Mulindu. I am from Kenya Moto. Kairi Hospital Church. It's a pipe on a problem. 296 ash. Ngasanya kwa chat. Wametumira kwa 2 piece. Kairi Amanda kusongera tukara mukradiki yako datawole bomba. alipirako n'abaana ku masukulu abo bali bombenji toyisuma sana.
Dial star 296 hash to auto boost and quickly grow your IO recharge with care cover each time you recharge. IO together with MTN. IO, because you care.
Right, welcome back, and thanks to MTN for making this conversation possible. If you are just joining us, we are discussing breast cancer, and Dr. Chiwe is just defining what breast cancer is and the different types of breast cancer that are there. He also told us factors, what the risk factors. One of the things he dwelt on so much is exposure to unopposed insulin. I'm going to explain what he meant by it. That's that age, advancing age, is a big risk factor to breast cancer. Also, he mentioned about certain things that we have, like obesity, alcohol abuse, certain contraceptives that are on for, especially if you're on or at prolonged rates, like prolonged time with breast cancer. He also mentioned that by it's a bit too late, so it's important that you go now. Take questions from our audience and me. I'll quickly, there's a very important question that I thought I saw earlier. Let me see if I can find it for you. Aha, this one here. So this question comes from Bridget Rubasi Mukuka. Her question is, can another type of cancer or other types of cancers in one's lineage, meaning family, predispose someone to breast cancer?
Thank you very much for the questions, Bridget. And I think the short answer is yes, and I'll give you a few examples. So we have what are called cancer, cancer predisposing syndromes. Things that are linked to a particular kind of genetic defect. There's something that happens in genetics in the family, and the most common when it comes to breast cancer is what we call BRCA, and BRCA is BRCA, which is basically breast cancer associated BRCA1 and BRCA2. This BRCA mutation is what controls the cell from growing and growing and growing. So everybody has BRCA in their bodies, okay? And we use that gene to make sure that every cell is under control as it grows and grows. The ones that get a mutation in families, in particular families, are predisposed to breast cancer in women and men at an earlier age. They're also predisposed to ovarian cancer in women and what we call fallopian tube tumors and peritoneal cancers. Okay, the peritoneum is what covers your lining, the intestines in the abdomen. For men, they are at risk of getting early prostate cancer. Prostate cancer, as we know, we start screening after the age of 45. But in families that have this BRCA-ness, we call it, they are at risk of getting prostate cancer much earlier than the general population. So yes, having, for example, if you tell me someone had prostate cancer before the age of 55 in your family, and it grew very fast, meaning it was very aggressive, or you have someone in your family that had ovarian cancer, depending on whatever age, there's a high risk that you are predisposed to getting breast cancer. And that's one of the examples I would sort of want to share.
Another very quick issue here. Chipampe Caesar Kaiser is just making a comment, and I want you to emphasize on this one. She's saying she had no idea that men can have breast cancer.
So the unfortunate, first of all, I did state that it disproportionately affects women because of the differences in the volume of breast tissue. But there's a 1% of all the breast cancers that exist in the world. 1% of those are in men, and because of, for men, it's like you've put it, Chipampe. Most men and the general population don't even think men are predisposed to breast cancer. They don't even think about it. So most of the time when we get breast cancer in men, it's usually very advanced, unfortunately, and it's more aggressive. So it's there, and I think we men also have to to rise to the occasion as well. This awareness is for everybody and also play their role.
Yes, I know, Doc, you are in Africa and you are in charge of the entire Southern African region. There's this question here by Katekelelwa Mundia. Where can we go for screening of breast cancer?
So I think last I checked in Zambia, every center where there's cervical cancer screening, I think you can get clinical breast examination. But the next level of where they should do radiological screening, you do sort of have to be referred. I'm not sure where those centers are, but for a woman to get a clinical breast examination, I think that's available in every place where there's cervical cancer screening.
Right. Anyhow, you may be interested to know, Doc, that here at CarePick Specialist Clinic, we do screen for 3 types of cancers. We screen for prostate cancer, cervical cancer. We also screen for breast cancer. So
that's good. That's great.
She can either come here or go to a hospital near her. It's good that Roche thinks we are doing great.
No, keep it up. I think the theme as well around early diagnosis is that early diagnosis saves lives. But I also wanted to state a point that early diagnosis also is cost effective. The earlier the disease is caught, the cheaper it is for you as the patient and for the system to treat you. And I've mentioned this in other fora where I think the late president of the US, John F. Kennedy, once said, don't ask what the government should do for you, ask what you can do for the government. If you want to help the health system be more effective and better, please go for early diagnosis so that you can make it cheaper and much easier for the health system to be able to tackle the breast cancer burden.
Right. There's this question here from Florence Catola, Doc. Can a 79-year-old woman suffer from breast cancer?
Absolutely. You can have breast cancer at any age. The difference is which type, as I'd mentioned to you, which pathology would you have because of your age. And commonly in older women, it's hormone related because, as I said, you've had a long exposure to hormones, and the treatment is also different. So it's also very important that when you're getting your treatment, please don't go around asking other people what kind of treatment they got. It's good to know the experience, but you might be treated differently because of the type of breast cancer you have and the stage that you have. And I should also state one of the things that happen, especially for older women, if you had your first menses at a much earlier age and you stopped having your menses at a much later age, meaning you had a long reproductive life from first period to the last period, there's a high risk of you getting breast cancer. So that also gives you that window into thinking of what is your risk category if you were early in your menses or you stopped having your menses much later.
Doc, is lactation also a sign of breast cancer?
Lactation in the absence of a child, meaning a breast discharge, because at that so because as I said, this is a discharge. So if you are not feeding a child and there's no child who's in front of you trying to get milk, just lactation happening on its own is a sign that there might be a problem and you need to get it checked. So a breast discharge, meaning milk as well in the non-lactating periods, and there's so many other discharge apart from milk. But at that point, we call it as a discharge.
Right. Now, this one here is a comment from Mutale Chibulembwa Kalikeka. Now, I need you to share some thoughts on this because I think she's making a very important point. She's saying, my mother was diagnosed with breast cancer last year, November. She just got back from India in July this year. We praise God, all went well, but it saddens me that if you want proper medical care, you need to go to India. We all can't afford India. My prayer is that Zambia advances in treating this horrible disease. Is Zambia capable of treating breast cancer?
Yes. So Zambia is capable of treating breast cancer.
Why are people
But
going to India?
they think the problem is the scarcity of the facilities to treat. Okay, we do have a very good cancer disease hospital with a running machine and oncologists there. We do have some private hospitals offering care, but I think almost every cancer treatment is very centralized. And because of being a single center, I think every cancer comes to Lusaka. For 18 million people, and Zambia, I think at the last statistics, we knew that you have about 13,000 cancers a year, which is basically a lot of cancers for one center. It makes it almost impossible to be able to provide care for everybody. I should tell you, Mutale, that this problem is not only in Zambia in terms of the African continent. I should give you a very sobering statistic that has shown that less than 50% of all African countries have access radiotherapy, one of the modalities required for particular breast cancers, and depending on your stage. And this has created this externalization of healthcare services to the West. 2020, there was an article that was published where Nigeria spent $1 billion of healthcare into Europe. So one of the things I think that I'm doing in my role, where we're looking at policy and partnerships, is to look at how can we optimize systems to be able to cater for themselves. And this requires a lot of partnerships, private sector, government, and sort of other organizations to be able to look at this together, and the patients themselves, like the affected families that you're talking about. Because I think leaving this entire challenge in the arms of government, I think we've seen is difficult. It's very, very difficult. So we in the private sector, I think with Dr. Mjajati as well, who's also doing screening, we're looking at ways in terms of how can we partner to make these systems be optimized to provide care within the countries. It's a long shot, but we are aiming at it, and we hope that we can be successful one cancer at a time, and we hope we can achieve some of these things in our lifetime. So it's sad. It's the reality, but one of the things we need to look at is it's a long process that is required to be looked at, and some of the things that I'm doing on the southern side of the continent is to see how best we can support systems to be able to reduce this kind of health tourism happening right now.
Now, you've said something very important, Doctor, that Nigeria spent $1 billion on external healthcare to like sending patients elsewhere. And I'm sure other African countries spend quite a lot of money. And my argument has always been that African countries like Zambia can actually appropriate that, revenue on the other side by strengthening its own systems and making sure that we are able to provide that care on the African continent. Do you think that's possible?
Absolutely, and I'll give you an example of one place where I did one of my fellowships in enhanced cancer training. In 1998, okay, Boston as a city, as a town in the US, had almost every cancer case being treated in the private sector. Okay, and the sort of the state sector was not as developed. But if you go to Boston now, you'll be amazed at what you get in the state, because they these are federal governments. Massachusetts changed in how they looked at cancer, and they just said we are going to do it ourselves, and the private sector is no longer as big. So the best place to get treatment in Boston now is in the public sector, which is sort of linked to the academic institutions. Okay, so it's very possible, and I think 1998, all of us were here. So this has happened in our lifetime. I think another country where although it's a different cancer, in 1989 or a year like that in Ukraine, they said we're going to be notifying cancer as a disease. In Poland, as we speak now, cancer is a red tag, meaning if you get a cancer in casualty, you expedite it as an emergency. So it's a notifiable disease. So we need to then sit together around the table as all stakeholders, and say, how best can we tackle this challenge and not leave it only in the hands of government? Because as we know, I've just mentioned, it's only 13,000 people that get affected by cancer, that sort of get a new cancer every year. If you look at HIV, it's a lot more. Malnutrition is a lot more. TB. So the prioritization of healthcare, or which problem government will sort out first, goes without saying that you look at which one is affecting bigger population. I think we've seen it with COVID right now. It's all hands on deck for COVID. So when you talk about cancer right now, it's not in the backseat, but it's not on the priority list, unfortunately and sadly to say that. But we can find ways to come together. Let me give you an example, Mutale. If that money you spent in India was spent in Zambia in the care sector, then you are empowering the healthcare sector within Zambia. But I'm not faulting you for taking your mother to India, but in a situation that Zambia was able to cater for your mother, that would improve the healthcare system. You spending the money within the country, because then you're empowering your healthcare system to grow. So those are some of the things that we're looking at, and some of these things we are we're giving them fancy terms, but that's exactly that. We're calling them innovative finance solutions. We're calling them blended finance solutions. All sorts of terminologies that are saying, can we all come to the deck, talk to governments, talk to the private sector, look at civil society, look at development finance institutions, look at development aid for health, and come on the same table and discuss this at length, so that we, as the community, say this is what we need to do for everybody.
Okay, away from policy and politics of health. Are women who started their menses at a younger age at higher risk of breast cancer?
Absolutely. So we call it early menarche. So if you're early menarche or late menopause, that's a higher risk, because you're exposed to estrogens for a longer period of time than the general population. So remember that risk is calculated from a starting point, not zero. And the starting point is general population.
Okay. This is Kate Machona. Her question is just a comment. It's a compliment to you. Sir, this is someone who understands the disease very well. Thank you, Doc, for bringing an expert, you see. Thank you. Thank you for bringing experts to the table. Okay, now, there's a question here on symptoms. I think you addressed this one, did you?
Yeah.
What are the symptoms of breast cancer? I think we went through.
Yeah, I think the important one is, let's start from no symptoms first, so that you get screened. Once you've got symptoms, you're going for a diagnosis.
Yeah. Okay, there's this here. What causes in the number of cancers? This is Vanessa Taurai Sibanda.
Thank you for that question, Vanessa. I think everyone wants to talk about diet as the main cause, but I think it's very multifactorial in the sense that, first of all, a lot of cancers existed before, but we were not capable enough to make a diagnosis. So there's that possibility that the healthcare systems back then were not advanced enough to pick up this disease. So there's that one. So we are now able to pick up disease. Secondly, I've just mentioned some of the risk factors. If you look at the older generation, if you look at our grandparents and their parents and their grandparents, some of these risks were not part of their environment. So our environment has changed. So I think in science, there's what we call phenotype is equal to genotype plus environment, meaning what you look like is because of what you're made up of and where you are made up and where you are growing up in the environment. So how you look, how your breast cancer comes up because of the genetics, what happens to the genes, and the environment. So we've gone into modifying the environment so much that it's increased the likelihood of people getting cancer. And sometimes I tell people that we have advanced our ways of living faster than medicine has caught up with. I've seen people, less people are walking than the ones that are driving now. So that's another risk. You see, people are not getting enough exercise. Previously, it was the other way around. There are much fewer people that were driving. People now have a lot more disposable income, so there's a lot more people are able to afford the lifestyle. They're eating out, so meaning they're not taking in organic food, I should state. or they're taking more alcohol, they're not exercising as much. So then we have, as a race, or as a people, we have modified how we live faster than our medical discovery.
As you hear, more of a complaint. What comment you can make? This is Chisengu Manjimela. I've had 2 mammograms, results lost at UTH. They report that when I bath, I feel pain on the left breast as I have a burn on the skin. Am I in danger? Now,
First
here's
of all,
the issue of who went for screening and they didn't have their results.
First of all, I should say sorry for that unfortunate experience in the system. But I should state that I think there is no perfect system, and we need to bear with the system sometimes. But we know the system can be better. And back to my issue, we need to sort of sit around the table together so that we look at some of these pain points and tackle them together in a very inclusive way, and not leave it to the healthcare workers to sort of say, healthcare workers and government, give us a solution. I think everybody has to come to the table and be able to provide the problem and the solution that they think should be in place. I'm not sure about saying danger, but I think you need to go and get it checked. I'm not sure if I'm allowed to say, but I know that Matero Referral Hospital has a very good system there where they're providing sort of a early breast detection program, and I think you could go there and get it checked. Dr. Mjalat, I'm not sure if I'm allowed to say this on your program, but I'm aware that two of my colleagues are working at Matero, and they're doing a great job in terms of early breast detection, and maybe they will be able to assist you there.
No, you are, because even ourselves here at Care Peak Specialist Clinic, when we have referred patients to Matero as well, after we've screened and certain things that we may not be able to do, we've referred patients to Matero. I think I remember referring a certain young lady to Matero, in fact 2 or 3 actually. So yeah, you are allowed to say that on my platform.
Thank you.
Because at the end of the day, it's about helping patients.
Absolutely.
Yes, and this platform is built to actually help society. So on this, we are allowed to say where people can get this help. You're allowed to say. For example, when you talk about collaboration between the public facility and the private facility, I think we have, as Care Peak Specialist Clinic, we have a very, very good symbiotic relationship with some colleagues in these public facilities where, we send patients, who sometimes can't afford the fees in the private sector. We refer them to spaces where we know that there the fees are more friendly and they'll still get the best of care. Yeah. So Matero is one such place where I like to send patients for breast cancer.
And I think I just need to add there to say one of the important aspects in the cancer early diagnosis and treatment is how quickly someone can walk the journey if they're caught with cancer. So it's back to the issue of how can we create systems that expedite people through that journey, because we don't want someone to have a lump and wait a few months before someone can do something about it, because cancer doesn't wait. So one of the things that we are sort of trying to challenge into the systems that we work in is to say, how can we get patients or people through these systems much quicker so that we save lives by early detection?
So can a bra cause cancer? For example, this second bra that
I think the easiest answer is no. So a bra will not cause cancer unless there's some other radioactive things that this bra came with. Clothing, there's no non-clothing that we know that is associated with breast cancer. One of the things that is associated with maybe it's not really causing breast cancer, but making it difficult to make an early diagnosis is maybe prosthesis, things that people put in their breasts. If people sort of get a breast surgery, some of those things increase the risk, but it's not a cause. It's not causing breast cancer.
Someone is asking here, Bridget Lubasi, what days do you do breast cancer screening at CarePick station? Oh no, at CarePick you have to make a call and book. We don't every screening once a week by book, so you have to make a book. Is this interesting? This is Michiko K. Chiputa. Doc, are women issues likely to get breast cancer?
So it depends also on which kind of hormonal balance we are talking about here. So I think if the hormonal balance is causing excessive exposure to estrogens, the answer there is yes. But if you've got a hormonal imbalance, then a gynae needs to see you. You need to see a gynecologist to be able to control that. And hopefully you're not moving into an estrogen driven exposure, because then that will increase your breast cancer. And hormone imbalances are in so many ways. It's just not estrogen and progesterone.
Okay, great. Yes. This question here. Thank you for this program. This question is from Aminet Banda. Doc, could you make a recommendation of a place other than CDH where one can do radiation? It can be in Zambia or nearest neighboring countries offering the service.
So I think I'd open to say in Zambia, unfortunately, only Cancer Disease Hospital has that facility. The private sector has not yet gone into getting these very cardinal services into play yet, and we hope that soon that will be a reality in Zambia. And I think I also mentioned that being one center for almost 10,000 plus cases a year is just very challenging for CDH to cater for everybody. And there's also it's just scarcity that is the issue right now in Zambia. And I also mentioned most African countries this is not available. It's only 50% of the countries that actually have access to radiotherapy. In the region, I know part of private sector in Zimbabwe, private sector in South Africa, private sector in Namibia, in Botswana, very limited as well. There are very, very few centers with radiotherapy. On the African continent, I think there are very few countries where there's maybe, I wouldn't call it excess, but adequate number of radiotherapy machines. I think from top of my head, I would think of Kenya and South Africa as countries that have readily available access to radiotherapy. But then if you're going as a foreigner, you're only allowed to use this service in the private sector, which then comes with a very added cost, which I think someone mentioned earlier. I think it was Mutale about India.
Doc, I think this is going to be our last question today. We are almost running out of time. But very quickly, Sichintu Lungu is asking, Doctor, can lactating women be screened for breast cancer?
Yes, they can.
They can. Okay,
they
great.
can
Now,
and they should. I've had one patient with breast cancer who had a 1-year-old child.
Oh.
They can.
Okay.
And please, that's not an indication for you to stay away from getting screened.
Okay. So, Doc, thank you for coming. And
thank you for having me.
I know South Africa is very cold. And I know Roche is keeping you very busy as you look after other African countries. Now, Doc, we want you to commit. We need you to come back at some point to come and talk about cervical cancer. Today we talked about breast cancer. Can you commit to the people who follow this page publicly that when we invite you to come and talk about cervical cancer, you come back?
I would really, really love to come for that. And I think we are right now, this year, we're working on these strategies for accelerating access to treatment for advanced cervical cancer in sub-Saharan Africa. I'm one of the people that is working on that project. on the Go Further partnership with PEPFAR, Bush Institute, UNAIDS, Merck, and Roche, seeing how best we can accelerate access to treatments for cervical cancer. And we hope that platform can then sort of spread its tentacles into other cancers. So I'll be more than happy to make time to talk about cervical cancer on this platform. And
Right.
Thank you for the questions. It's been great to hear what is out there.
Right. So now, Doc, what is your final word? If the people who are listening to this program from the beginning up to now are still here, which I see most of them are, what is your final word? What's your take-home message? If they forget everything you said, what is the final take-home message from you to them?
The best time to get a diagnosis for breast cancer is before you can feel it. That's the best time. And remember that this does not only affect women, it affects families. Zambia is very special in the sense that 60% of families are women run. So when a woman is affected, 60% of the country is affected. I think that's the point. So we all need to rise to the occasion and be part of this awareness. And Awareness Month does not mean that's the only time we should be talking about breast cancer. It just means that's the time we're dedicating from the healthcare professionals to say, can we share this responsibility with the general population to say, please take responsibility as well as we try and do something about it. But we need to look after ourselves through and through. So I think one of the taglines is check your breast every 30 days, meaning make sure you check yourself. That's awareness, that's not screening. And please go for a screening if of a particular age, so that we can catch it early. Early detection saves lives and is cost effective.
Doctor, thank you very much for coming, and please greet the people at Roche, and would like you to tell people at Roche that we are very grateful for you to join.
Thank you for having me and having invited us to this show.
Do take care, Doc.
You too, thank you.
Okay, so there you have it. We had Dr. Chiwesa discussing breast cancer, and as usual, ladies and gentlemen, click that share button. We need this information out there. We need everyone to get this information as much as possible. I know that people were watching football, and quite a number of people did not just watch this, but I know that they may watch it later. But share this video on as many platforms as you can, because this information is critical, especially for our women folk. Until next time, do take care and enjoy watching football and the rest of the day.